Now let's cover the gastric bypass procedure. There are several accepted names for this procedure, including gastric bypass, Roux-en-Y gastric bypass, or even simply, RNY. For many years, the gastric bypass was the gold standard in weight loss surgery. It was done for a long time with an open technique that resulted in high complication rates. Nowadays, however, the bypass is done with a minimally invasive laparoscopic technique, leading to a much safer procedure with faster recovery. Journey Light surgeons have done thousands of successful gastric bypasses. Before we get on to talking about the bypass, let's recap how surgical weight loss works. There are two categories of procedures, restrictive and malabsorptive. Restrictive procedures work solely by reducing the effective size of the stomach. Both the lap band and the gastric sleeve are restrictive procedures. After a restrictive procedure, a patient will still absorb all calories they consume, but they will simply consume fewer calories because they are getting full earlier. The restrictive procedures are covered in separate info bits. A malabsorptive procedure, on the other hand, incorporates not only a reduction in the effective stomach volume, but also involves bypassing some amount of small intestine. After a malabsorptive procedure, a patient will typically not absorb every calorie they consume, depending on the amount of small intestine getting bypassed. The duodenal switch, SIPS procedure, and gastric bypass fall into this category. Duodenal switch and SIPS will be covered in a separate video. Let's take a look at gastric bypass anatomy, which incorporates both a restrictive and a malabsorptive component. First, a small gastric pouch is created at the top of the stomach. This is the restrictive part of the operation, as patients will be getting full on much smaller portions after surgery. Once the pouch has been disconnected from the remaining stomach, the surgeon will divide the small intestine about 4 to 6 feet downstream from the duodenum, and then pull it up and connect it to the pouch. Then, a new connection is made between the two sides of the small intestine. You can see from this diagram that digestive enzymes made in the stomach, pancreas, and liver will be kept separate from any food taken in until they both reach the common limb, where they mix together. The common limb is actually much longer than is shown in this diagram, but varying the length of the common limb can either increase or decrease the amount of malabsorption that occurs. For pros of gastric bypass, it has a little more power than a gastric sleeve, and a lot more than a gastric band. Weight loss is therefore a little faster than with a gastric sleeve, and a lot faster than a gastric band. Remission of type 2 diabetes is a little better with bypass than for gastric sleeve, and a lot better than for gastric band. Lastly, the bypass is more time-tested than just about any other surgical weight loss procedure. On the downside, this operation is much more complex than sleeve or band, and therefore carries slightly higher risk. Also, bypass patients face risks for complications years down the road from surgery, such as vitamin and nutrient deficiencies, pouch ulcers, and others. Lastly, the gastric bypass is not adjustable and not easily reversible. Now let's look at the main short-term complications seen after gastric bypass. Similar to gastric sleeve, staple line leaks can happen in up to 1% of patients, usually within the first 30 days of surgery. The risk of this complication can be increased in revisional procedures like gastric band to gastric bypass conversion. Unlike with sleeve, leaks usually happen early and are much more aggressive. Most gastric bypass leaks will require emergency surgery to correct. Bleeding is also a recognized short-term complication of gastric bypass that occurs in up to 0.5% of cases. Typically, if there has been no signs of bleeding within 24 hours of surgery, it will not happen beyond that point. There are several long-term complications that can occur after a gastric bypass. An ulcer at the junction of the gastric pouch and small intestine, called a marginal ulcer, can occur in up to 1% of patients. This risk is greatly increased in smokers, or in patients who use non-steroidal anti-inflammatory drugs such as aspirin or ibuprofen. Because of this risk, a gastric bypass is not recommended in a patient who is actively smoking, and nicotine testing will be done to ensure a patient is smoke-free prior to surgery. Also, patients with severe arthritis who require daily NSAID usage may be better off considering another procedure. Hypoglycemia, or low blood sugar, can be an issue after a gastric bypass, however this can typically be treated medically. Internal hernias and/or bowel obstructions are a risk after gastric bypass due to the additional work that is done on the small intestine. Also, vitamin and/or nutrient deficiencies can occur due to the small intestine that is bypassed, causing malabsorption. Lastly, the mortality rate of gastric bypass is similar to gastric sleeve at around 0.1% or 1 in 1,000. As for the procedure details, the typical operative time is about 2 hours. During the procedure, 5 to 6 small laparoscopic incisions are made, and a camera is used to perform the operation. Bypass patients will require an overnight stay, but most can go home the morning after surgery. After surgery, the diet progression is the same as for gastric sleeve. Patients must follow a liquid diet for 1 week, followed by pureed food for 3 weeks, and then advance to solids. Typically, monthly visits are required in the first year after surgery, and although a live visit is always preferred, we can arrange for virtual video visits for our out-of-town patients. With regard to time off work, most patients with a non-lifting job can go back in 1 to 2 weeks. For a lifting job, however, it's usually 3 to 4 weeks. Thank you for watching the gastric bypass video. For more information, go to journeylight.com/bypass.